So now we will see about the screening and prevention. So first one is CA125, that is CA is cancer antigen CA125. CA125 was discovered in 1981 by Bass et al. in 125th attempt to make the serum marker using hybridoma technology. Although it is the only US FDA approved biomarker for ovarian cancer detection, it is only expressed in approximately 75% of the cases and principally in the serous subtype. It is not expressed by mucinous or the other ovarian carcinoma. When this decreases are metastatic to the abdominal cavity, CA125 may be aberrantly elevated, although not reliably enough to accurately reflect the intra-abdominal tumor burden. Additional shortcomings of CA125 include a lack of sensitivity for detecting early stage ovarian cancer and potential presence of this protein at abnormally high levels in many benign gynecological and non-gynecological conditions, and for these reasons CA125 is not a suitable screening test for ovarian cancer in general population. The search for more sensitive and informative biomarkers continues. Accepted uses of CA125 include helping to determine whether a pelvic mass is malignant, assisting in determining whether a cancer of unknown primary origin is arising from ovary, monitoring response of ovarian cancers to systemic therapy, carrying out surveillance of potentially treated for ovarian cancer who are in remission, screening for ovarian cancer in high-risk population, patients with a strong family history of BRCA1 and BRCA2 mutations. Now, prostate, lung, colorectal, ovarian cancer screening trial, that is PLCO trial, was determined whether screening reduces the mortality from ovarian cancer in hereditary women between age 35 to 74 years who still have their ovaries, and a total of 34,000 women were enrolled in this trial, were randomly assigned to either no screening or yearly transvaginal ultrasound plus CA125, and a total of 90 patients were diagnosed with ovarian cancer out of this 34,000, of whom 60, that is 67%, detected through screening with ultrasound and CA125. However, 72% of the screen detected cases were late stage, that is stage 3-4, and for every 20 women undergoing surgery, only one case of the ovarian cancer was discovered. Unfortunately, 15% of those who underwent surgery suffered serious complication. Ultimately, it was determined the screening did not significantly reduce mortality from ovarian cancer. So in 2012, Murray et al. They studied the blood samples taken from patients in the PLCO trial and reported approximately 62% of the 65 patients had C125 data available in blood sample collected less than a year before their ovarian cancer diagnosis had an elevated C125 level. And this scientist probed the same blood sample for 7 other promising biomarkers. However, even when combined with CA125, this panel of markers not found to be more sensitive than CA125 alone detecting in ovarian cancer. So in 2017, update from PLCO trial, Tamkin et al. Reported that histological heterogeneity in this disease impacts the detection and survival. Then risk of ovarian cancer algorithm, ROCA, risk of ovarian cancer algorithm, developed to improve the sensitivity of CA125 in detecting epithelial ovarian cancer. And CA125 for an individual woman is used as a yardstick against which fluctuation or changes in the CA125 over time can be measured. Risk estimates or ROCA score of developing ovarian cancer then to be provided by imputing this CA125 changes into a mathematical model that includes the age of woman. Hypothesis is that CA125 level should steadily increase over time in women who is ultimately going to develop ovarian cancer, whereas CA125 level would be expected to remain typically clinically stable or even decrease in those with non-cancerous condition. And theoretically, by monitoring risk of ovarian cancer algorithm score carefully, disease may be intercepted before it starts to spread and leading to higher cure rates. So US ROCA study sponsored by the National Cancer Institute Cancer Genetic Network, Early Detection Research Network, and the Ovarian Specialized Program Research Excellence, and in this single prospective multi-center screening of 4,000 patients of 50 to 74 years with no significant family history of breast or ovarian cancer underwent an annual C125 blood test, and based on the ROCA result, women were triggered to the next annual CA125 test, low risk, to repeat CA125 in 3 months in intermediate risk, and to transvaginal ultrasound refer to gynae-onco in high risk. And based on the results of the clinical examination and the ultrasound, gynae-oncologists then made the decision as to whether to proceed with surgery. So average annual rate of placement of study participants into the intermediate group was 5.8%, whereas annual rate of transvaginal ultrasound and consultation in the gynae was 0.9%. So a total of 10 women underwent surgery and 4 invasive cancer, 1 in stage 1A, 2 in stage 1C, and 1 in stage 2B, and 2 ovarian cancer were low malignant potential, that is both stage 1A, and 1 stage 1 endometrial cancer, and 3 benign ovarian tumors were detected, providing a positive predictive value of 40% detecting of invasive cancer and specificity of 99%. All 4 women with invasive cancer were enrolled in this study for at least 3 years with a low risk annual CA125 test values prior to increasing level of CA125. And these results are consistent with the UK collaborative trial of oncology cancer screening, and the specificity of 99% reported in the UK study that was similar to US study, and positive predictive value of 37.5%. ROCA can detect early stage ovarian cancer in the general population. Survival and yet not yet mature to determine whether the ROCA can reduce the mortality rate for this disease. And eligibility criteria for UK familial ovarian cancer study group included more than 10% lifetime risk of ovarian cancer, age younger than 35, and no RRSO. Phase 1 Rosenthal et al. Showed annual transvaginal ultrasound and CA125 screening in women at high risk for ovarian and fallopian tube cancer lacked sensitivity for early stage disease, but may result in an improved optimal debulking rate when patients are taken to surgery. And for women at high risk who differ or decline RRSO, ROCA is an acceptable alternative given in high sensitivity of 94% and significant stage shift of 1 to 2, and although its impact on mortality from ovarian cancer remains unknown. Skates et al. Collected data from the Prospective Cancer Genetic Network and gynae-onco group trial, screened 3,000 high-risk women with germline BRCA1/2 mutation, strong breast and ovarian cancer in family, and evaluated C125 values drawn at 3-month interval with the ROCA. And the investigator reported that in this high-risk population, ROCA evaluation every 3 months had better early stage sensitivity and high specificity compared with CA125 more than 35 unit per ml every 6 months to 12 months.